So it's a real privilege to be here today. Thanks for coming. Thanks for inviting me. And you're all very, very busy. And so giving up a day to come learn about value-based payments is a big ask. So we appreciate that. One correction to what Christine said is I'm not the Medicaid director. That's Jason Helgerson. I'm the medical director in Medicaid, the Office of Health Insurance Programs. Our Medicaid program is a big program. What enticed me was one thing was just the volume. We're the largest payer in the state. The state population is 19 million people. Medicaid impacts between 6 and 7 million people every year. Not everyone continuously enrolled, but it is a large program. We are second only to California in terms of Medicaid coverage, covered lives in the United States. And in New York, we were very progressive, and we were offering health insurance and the exchange and promoting insured covered lives long before most other states, with the exception of California, who is equally moving forward. I think I'm a primary care physician at heart. That's how I feel. That's how I started. And in fact, after medical school at Ohio State, I'm from Ohio originally, I planned to do primary care. I did a lot of my electives in the primary care setting and did my first year of family medicine residency until I decided that I wanted to pursue infectious disease. And in order to do that, then I had to do an internal medicine residency to pursue that pathway. Long had an interest in infectious disease, and then in particular HIV, and that became the area of specialty. So for the 21 years when I was full-time at Albany Med, we were the primary care providers for our patients, so they got their specialty care from us as well as their primary care. And in the beginning, we never thought we would live to have this luxury, to see the luxury of being able to do health maintenance for people with HIV. But as treatments got better, the drugs got better, everything evolved. We learned a lot, and I think what I learned through the AIDS program and through the AIDS delivery system here in New York, the Designated AIDS Center that the Health Department has through the AIDS Institute for care delivery with care coordination, integrated care, really kind of set the stage for what we're trying to do in our delivery system reform incentive payment program, DSRIP, and in value-based payments. So, for example, we had HRSA-funded dollars. These came from the federal government through the Ryan White Care Act. If you remember who Ryan White was, the hemophiliac from Kokomo, Indiana, who was diagnosed with HIV from his factor infusions, and his mother was supported by some prominent folks, and was encouraged to go testify before Congress at the request of Senator Kennedy to procure those dollars for HIV, that it wasn't just a marginalized population, but this was a condition that was infecting many, many people. So those dollars and support still exist. The Ryan White Care Act gets reauthorized every 3 to 5 years. Last I heard, it hadn't actually been reauthorized, but it didn't have a sunset clause. But it enabled us to, over the years, have an on-site care manager for our patients. We had a alcohol substance use counselor, a KSAC counselor. These folks knew the resources in the community to help us engage in the community and help keep our folks successful and out of the hospital to the extent possible. In 1994, when I came to Albany Med, our inpatient census for the HIV service was 23, with the census sometimes writing 30 to 33 inpatients. I still do rounding on the weekend and cover as a consult service, but when I left, we moved from being kind of the hospitalist for our patients, admitting for our group, to becoming a consult service. So now I'm only rounding, consulting on 5 to 6 patients. That's all in the entire house at any given time. So this is testimony, I think, to many things that have come together, one of which is certainly better treatments, right, the drugs. But we also had to learn how to get folks to take them. Back in the day, the antiretroviral regimens were a meal unto themselves. One of the drugs, sequinavir, was 18 capsules just for that one drug, 3 times a day in the beginning. Now we're down to single drug therapies, so yes, the drugs have helped us tremendously. But we had to put in place some of these supports, wraparound services for the referrals to the community, but we also always had on-site, at least an LCSW, and most of that time a psychiatrist, part-time, not employed by us typically, although in the beginning that was the case because there was such a need, but now more just funded, so with dollars that we get, that we used to support an FTE out of the Department of Psychiatry. So there are lots of models and lots of examples out there. I think HIV care has really been a model where care has been integrated, and over the years it came to be called, in our hospital at least, HIV exceptionalism. You had to have HIV in order to kind of get some of these special things, some of these special benefits and supports that other Medicaid members didn't have access to. And so with DSRIP and VBP, we're trying to put those supports in place, show the return on investment. They are kind of low investment for the great gains that one can see in terms of care transitions from the acute care setting to the outpatient setting. I think one of our most successful initiatives was using peers. So using peers who had been diagnosed with HIV, they had the condition themselves, going to the bedside, being a familiar face, offering that reassurance when they were newly diagnosed with an opportunistic infection, and then helping to make sure that they got to the outpatient setting. And if they didn't show up, why didn't they show up? We had a 30 to 50% drop-off between the hospital and getting to the clinic. So if we didn't track and follow those folks, they were lost out there and only going to come back in and recycle. So much of what I'm going to say now is really about trying to offload these acute care settings so that patients get the kind of care that they need in the appropriate setting. The emergency room is not the best place for respiratory infections and a lot of primary care things that can be dealt with, but it is kind of our ipso facto default. And it would drive me crazy when I would hear our nurses in the clinic say at 3 o'clock, oh, it's 3 o'clock, go to the emergency room, just because of the system. So Jason Helgerson, one of the stories he often says, and I don't know if you've heard him say this, but our Medicaid director, in healthcare, we don't do such a good job of kind of trying to meet the person, the consumer, kind of where they are. So Amazon does not say at 5:05 or 4:05 on a Friday, oh, we're going to be closed for the weekend, but we certainly love your business. Call us back on Monday morning. And in the meantime, though, if you have an urgent need, you could go to the Walmart of one of our competitors. So I think it's a very good example of really what we can try to do better in healthcare. And it doesn't mean, I know we're all human. We can only work so hard, and everyone is working really, really hard. It's about trying to work smarter and work together and coordinate between acute care settings and outpatient settings, urgent care centers, having a facility of transfer of information so that if our member, our patient is going to an urgent care center, that we be sure that we know that we're getting this information fed back and forth and that we're kept in the loop. So having agreements with these places so that we can get that information and know in real time, I think, brings great value. So my goal today is really to cover the goals of value-based payments. I think probably Courtney and Greg talked about this this morning. Then we'll talk about the VBP arrangement types, and then I want to go into the various levels. We have 3 levels of value-based payments that we're offering in Medicaid, and go into exactly how these payment scenarios work with each of the arrangements. Then we'll talk about quality measurement in our arrangements, the categorization of the measures and the ones for the primary care settings, and then some top 10 things to think about and kind of a summary at the end. Any questions as you come along, don't be shy. This should be as interactive as you want it to be. So appreciate questions as we go while it's relevant. I thought I would begin just with a little bit of terminology. It may be obvious to you, but it wasn't to me when I went from the clinical side to the government side of healthcare. I thought I knew what they were talking about sometimes and realized they were talking about something different because of the way the terminology was being used. So one thing in government speak is when people say behavioral health, at least in New York State government, it means not just mental health, which is what it meant to me, but it includes substance use disorder care. So when we say behavioral health in New York, we are talking about services certified or licensed by Office of Mental Health or OASIS, or those services that are provided in primary care settings through the Department of Health. Efficiency is the term that we use for actual cost over targeted expected cost or budgeted costs. So did we come in under budget or over budget? But typically, just as it occurs now in a level 1 or level 2 VBP arrangement, care is delivered, a claim is submitted to the managed care organization, the claim is paid. That's what we call a fee for service, kind of a remittance of payment, as opposed to Medicaid members who are either in managed care or fee for service. So out of our current 6.3 million people, 6.5, whatever the actual number is, who are in Medicaid right now in New York State, about 1 million are left in fee for service. A large group is still those with intellectual developmental disabilities. The plan is for those to start to be rolled into managed care on a voluntary basis in the summer of 2018 and moving on. But there are still populations that are not yet in managed care. When we're talking about VBP and Medicaid, we are only talking about those who are in managed care, so about 5.5 million people. Medicaid MCOs, these are the managed care organizations in the Medicaid program. So there are 15 really what we call mainstream Medicaid managed care plans, and there are 3 HIV special needs plans, and then some 60 or 70 managed long-term care plans. What I'll be speaking about today is not so much about managed long-term care, but the others that are delivering primary care services. Provider is a term that can trip us up pretty easily because we think we know what they're talking about, but they may be using it in a different context than what we understood it to be. So a provider in government speak can be a practice, it can be a hospital, it could be a nursing home, it can be a community-based organization, any provider of services, if you will, as opposed to, I think, what clinicians think of, what nurse practitioners and physician assistants and doctors and nurses think about is that a provider is a person who has direct contact with the patient and is delivering services. So even PCP, that terminology, people may be thinking, you may be thinking they're talking about the doctor or the nurse practitioner when they're actually talking about the provider organization or the practice itself. So just kind of be aware of that and know that it may be a little bit different than what we're thinking about. VBP contractor is our term for the provider or group of providers who are engaged with a managed care organization and Medicaid in a VBP contract. So when we say VBP contractor, that's kind of the provider group, whether it's an IPA, an ACO, a hospital-based health system, a group of primary care docs. And then the VBP roadmap, this is our CMS approved document. This is our document. It's about 80 pages of standards, guidelines, and recommendations that pertain to VBP in our New York State Medicaid program. This gets renewed and updated each year. So it was first approved by CMS in 2015. Our 2016 version got approved by CMS in this new administration this year in March, and we just finished last week the updates for 2017, and those are being submitted to CMS for their review and sign-off. So what is VBP in relation to DSRIP in our old world? So in our kind of standard world, as Greg probably talked about this morning, in our fee-for-service world, this is where just services are provided and they're paid. And it, in some ways, I think, incentivizes sickness. It's just, there isn't that kind of built-in, I think, incentive to make sure that we've done a really, really good job and a tight discharge to make sure that people don't bounce back within 30 days or 60 days or whatever. Because we pay the same, whether they come back once, twice, or 3 times. But we really want to use those dollars smarter and move them to the front side where we can give smarter primary and preventive care to prevent those admissions and readmissions. The ER will tell you they're plenty busy. No one's going to lose business here in a significant way, especially through ERs and a lot of the hospital beds. I mean, there may be some offloading of hospital beds, but there's still plenty of folks out there. ERs have a turn-away rate every day of patients who show up. I think it's like 6% on average, who they don't ever get to see, who walk away because they had to wait so long to be seen. So getting these folks to the right setting. DSRIP is really this kind of 5-year transformation effort that we think of as kind of a no-risk, shared savings opportunity for providers and practices to kind of help change workflow, increase workforce, try to work on expanding primary care in the avenues that are available to us to get ready for the VBP world for this commitment to 80 to 90% of payments being in a value-based payment arrangement. And then 2020 VBP is really seen as the sustainability limb of the DSRIP program. So I think you've probably heard this morning, this requirement, and this is in our roadmap and in our all of our documents with CMS, that these arrangements for those in managed care, that 80 to 90% of the payments to providers will need to be in some kind of value-based payment arrangement, and plans will have penalties if they do not meet these metrics with providers. So what is VBP? It's an attempt to reward value over volume, trying to incentivize providers for this opportunity for sharing in the savings that are right now are invisible to providers. So if there are efficiencies and a practice has been highly efficient, kept people out of the hospital, then those savings are really realized only by the managed care organization, and they're not passed down to the provider because there wasn't a target budget set out at the beginning to which to compare it. It's a method to tie payment directly to quality and healthcare outcomes with both process measures as well as outcome measures where we have good outcome measures. And then, as I said, it's this kind of sustainability limb of the DSRIP program. What I'm talking about today is the relationship, again, of the managed care organization to the VBP contractor. There is another relationship that the state has with the managed care organizations around rate setting and around their quality improvement programs and through the QARR program, QARR, which is the Quality Assurance Reporting Requirements. So the VBP contractor, again, may be an accountable care organization. This is the provider organization with whom managed care would be contracting. It may be an independent practice association, an individual provider, a large provider group. Also, the other piece in setting a target budget, which we'll talk about a little bit more, high quality providers, so providers who are already performing at a high level, there are incentives and some stimulus dollars that will be added on. So there's a calculation and a formula that's detailed in the roadmap so that they'll have a higher target budget set in the beginning. It's good to have a higher target budget. That means you've got a higher ceiling within which to come under in terms of your budget for that year as you think about setting up a budget for a specific VBP arrangement. And then the quality performance really then is these measures are what determine the percentage of shared savings or losses that would have to be paid back in a level 2 or level 3 arrangement where there's risk. So now let's talk about the arrangement types and what these entail. So these are the various arrangements. They're all listed here. So TCGP is total care for the general population. So this is an all-inclusive arrangement for all members for all of their services that would be required. One important caveat is total care excludes these subpopulations. These subpopulation arrangements, such as for the HIV/AIDS population, are also total care arrangements for these given populations. And they are excluded from total care for the general population because it was recognized early on that these are higher cost populations. The HARP members are those with serious mental illness and substance use. HARP is our health and recovery plans. So these are specific managed care organizations that have taken on these members with serious mental illness and substance use. So they're higher cost, so the HIV/AIDS population, higher cost MLTC, and when those with intellectual developmental disabilities come into managed care, they'll be involved as well. But these are carved out of the total care arrangements. But total care includes all the costs of care that occur with a member in a given year, or with the patient. There can be certain carve-outs that can occur, so dental may be included, or one may decide that you don't want to include dental services in your total cost for the general population, as an example. Maternity costs would be in, although we also have 2 episode-based arrangements. One is maternity care and one is integrated primary care. And I'll go into these in a little bit more detail, but those are a little bit different arrangements. So let's start first with total care for the general population. The goal is to improve population health through enhancing quality and total care for these individuals, and so working to think about population health. And I think a big caveat here is this last bullet here. All patients attributed to the arrangement. It's not just who walks in our door, who comes and sits on us in a clinical practice across from us and checks in, but it's those other members who the plan says are my patients that aren't in care, that we haven't seen, that I don't even know are my patients. This also incentivizes trying to align and making sure that the managed care PCP, the plan assigned PCP, is who the patient thinks it is and who I think it is. So the patient comes and they think I'm their doctor, but it turns out, you know, Dr. Brown is actually listed because the patient never actually followed through and enrolled, so they got auto-assigned to PCP. So efforts such as this to align those will be important in a value-based payment world. So in this world, again, the total population excludes these subpopulations. If a contractor, a provider group wants to include them, they're welcome to, but there is not a requirement in the approved roadmap for doing so. So that it's left over this general care for the population minus the subpopulations. And just want to remind myself to say that all of these arrangements and the way that this got worked out was through multiple stakeholder interventions, through provider groups, associations, trade associations, managed care organizations, meeting many, many times around the technical design to try to meet the needs of patients in New York State. So these are specific to New York State. In the case of the episodes, some of them have been designed by Alterum, the company that I'll talk about for these arrangements, the grouper for the claims, et cetera, specifically tailored for New York. One of our episodic arrangements is integrated primary care. So this includes preventive care. So typically the wellness care, the visits, checkups, screening and routine tests, et cetera. Immunizations will probably stay out as a fee-for-service component so that those would still be paid for as they're given. If we believe that fee-for-service drives volume, we want to drive volume of immunizations. We want that rate to be high, so those would likely actually be kept out, but they're certainly part of preventive care. We would still pay for them separately. Sick care, what patients come to primary care providers for with their regular complaints, belly pain, abdominal pain, headaches, and those kinds of things, as well as chronic care for these 14 chronic conditions. These 14 chronic conditions were defined because these are the ones that are of the highest prevalence and the highest cost to New York State Medicaid members. And you'll notice that there are 4 behavioral health conditions in here: bipolar disorder, depression and anxiety, PTSD, trauma and stressor, and substance use disorder. So these are the high cost things. And these members have a fairly high cost too. Those, again, with severe illness could be carved out of a total care arrangement and would be not included. But we're talking about these services that are amenable to primary care. So everything that's in an integrated primary care arrangement is really what is under the jurisdiction and potential domain and impact of a primary care practice. So the goals are to improve quality of preventive care and sick care and avoid some of these conditions resulting in higher cost utilization of ER and the hospital. So also an IPC contract for integrated primary care could also do a level 1 total care arrangement. These are not mutually exclusive, but both could be done in a given situation. So the arrangement type year for contracting would be January to December. The grouper for this group, for this episode, is called the Prometheus Grouper by a company called Alterum. So they are offering and helping us with this kind of grouping of claims in Medicaid for both the integrated primary care arrangement as well as the maternity arrangement. These are fairly unique arrangements that are specific. They're not like a total care arrangement. Integrated primary care, if you look at all the costs in Medicaid that are delivered, primary care is about 40% of that cost. 60% of it is more kind of specialty care, subpopulation care, et cetera. And again, I mentioned already that 4 of these chronic episodes that are included are behavioral health. Maternity care includes if a contractor decided to choose maternity care, it includes the prenatal care, delivery and postpartum care up to 60 days after discharge for the mom, and newborn care up to 30 days post-discharge for the infant. So the primary attributable or responsible, if you will, clinician for maternity care would be the obstetrician. The guidance for the roadmap is that the obstetrician would be the one who gives the predominance of care. So typically that would be the person who gives the prenatal care because that would be the provider that has most of the care for a mom during pregnancy. If someone comes in without any prenatal care, then it would be the delivering obstetrician. When Texas did this, they actually started out using the delivering obstetrician as their attributable provider, and there are different models that can be done, and even in the arrangements, one could choose to have it be the delivering obstetrician as opposed to those giving the prenatal care. But the guidance is from the roadmap for it to be those delivering most of the care. So what triggers it is actually a delivery, so that's what triggers an episode, if you will, to incorporate claims. So it's either a vaginal delivery or a C-section with a 270-day look back for the pregnancy, and then that follow-up 60 days after birth for the mom and 30 days after discharge, rather, for the newborn. One of the concerns was the high-cost NICU care. Well, is it fair to have NICU costs included in there, especially these high level 4 NICU costs for the revenue code that's for that level 4 care. And we think it's actually better if it's included than if it's not for a number of reasons, one of which is that it's just it's easier for implementation, and I think decreases the risk for gaming and having patients being moved from one center to another. Remember that the target budget that gets set for an arrangement includes the past 3 years of claims and experience that a provider organization has with a given population. So if you're an obstetrician, you would look at your last 3 years worth of claims and charges and the cost of that care. The first year look back is about 35% or 50% of the weight, and then the second year look back is about a third of the weight, and then about 15% of the weight is the third year. The goal is to try to kind of get an average understanding of what that cost is that helps inform the target budget that then you would be compared against at the end of either an episode or at the end of a year. So if you're a hospital that does level 4 NICU care and is certified to do that, then those costs are already going to be included in your target budget because you've been doing it all along. So it's not like you're delivering care that you weren't delivering before. It's actually included. But the recommendation is to have a stop loss. So at some point, is it $50,000 if you have, a preemie baby that costs $75,000? The highest limit your cost would go would be $50,000. So that's what we mean by having a stop loss. And that is what most experts have recommended around a maternity type of arrangement. And this can be included in other arrangements as well for kind of catastrophic or extreme costs. Total care for the special needs population. Again, this is kind of like total population, only it's all those costs for these subpopulations. So if we think of the complete population minus that population that is the total care population that we talked about initially, leaves you with these subpopulations. So it's an all-in. It's not only their HIV specialty care and an HIV arrangement, but their primary care services too that would be included in the cost for those services. So for example, in our HIV practice, we did the primary care, we would be well poised to do that. You need for a subpopulation arrangement at least 1,000 members at a minimum. So we think there are some plans and practices in New York City who may be interested in doing an HIV subpopulation arrangement in the next year or two. We haven't heard of any interest yet upstate, but I certainly think there would be opportunity. And even in our practice where we had about 1,600 HIV patients, we could do an HIV subpopulation arrangement. So let's now talk about the levels in a little bit more detail. Level 0 is kind of what we have now. It's fee-for-service with quality bonuses that are offered by some plans for high-quality practices. Level 1 and Level 2, these are still, again, these are a fee-for-service, so it's kind of business as usual. The difference is that you have a target budget that's set at the beginning of the year, and at the end of the year, you look at your costs, collect all the claims. There's that claim lag of 4 to 6 months, so you wouldn't know kind of till all those claims were adjudicated. But at the end of that year, did I come in over or under that target budget? And if we come in under that target budget by, let's say, $1 million, then you have $1 million to share. It doesn't all get then just absorbed by the managed care organization, but can be split. And in a Level 1 arrangement, that split, that recommended split is a 50-50 split. So that $500,000 will go to the provider organization to then incentivize and be used back to support infrastructure, quality improvement processes, and to do other things, to hire a care coordinator, a care manager, to support a peer for your high-risk populations, whatever that is, whether it's the diabetics, the type 1 diabetics, those with sickle cell, or whoever is really costing you a lot in terms of hospital utilization, to make sure that they follow up. So again, Level 1 and Level 2 are these arrangements looking back retrospectively reconciled against that target budget. Level 1 is upside only, and when we say upside only, we mean, so even if there are losses, even if a practice, a provider group that's done a contract comes in over budget, they're not going to lose out. It's neutral. Those costs, those losses get absorbed by the plan. So that's what we mean by it's upside only, that there's not risk here. It's been pointed out to me that there's potential risk if you're already doing Level 0 and you're a high quality provider and you rely on these incentive quality payments that you've been getting every quarter because you do so well at keeping people out of the hospital, then is there risk if you go from that level to a Level 1 where now the the rules of engagement are a little bit different. But it's by and large the same kind of quality metrics that we're looking at. So if you're a high performer in our current world, you're going to be a high performer in a VBP world as well. So in a level 2, because the practice is now more mature, more comfortable with VBP, understands it, more comfortable, willing to take on some risk if there are losses. The recommended guidance for that sharing, let's say there's that $1 million, the recommended sharing is 90-10 as opposed to a 50-50, that 90%, $900,000 would go back to that IPA or that ACO to reinvest with their provider network and their partners for quality improvement processes and other initiatives. Because they're willing to take on some risk, up to 50% of that risk, depending on the quality metrics, up to 90% of the risk if there are losses. And then level 3 is not this retrospective reconciliation against a target budget, but it's a prospective capitation model, a per member per month. So what we mean by that is there's still a target budget that gets set in terms of total dollars that would be available, but the practice, the IPA, is getting these dollars ahead of time, not retrospectively, in a monthly or quarterly payment from the plan to care for those members, but it's all the money you're going to get to care for those members. So that's why there's risk, because you're taking on that full, you're kind of becoming the insurer, if you will, for that patient population. So let's walk through some hypothetical arrangements and what this would look like. So in a level 1 agreement, the roadmap recommendation is that 50% of the savings be shared. And again, this important caveat, when a percentage of the quality metrics get met, and the roadmap guidance is also for 50%. So if you have 10 measures that you're going to pay on, 10 quality measures that you've agreed as a practice, as an IPA, with the plan, that these are going to be the measures on which we're going to be paid on. If you meet half of them, 50%, then you're eligible for the shared savings. So just because there are efficiencies, just because we come in under target budget, isn't a guarantee that they would go to the provider, go to the contractor. The quality metrics need to be met as well, at least half of them. So in this example, we are calling the payer Forest Land Care. This is the managed care organization. The state gives, in this example, $6,000 to the plan to take care of that member for that year. It's a $500 per member per month. 500 times 12 gets us to that $6,000. The provider delivers care to a member, and we're looking at an individual member level here. And let's say that they submitted claims for $4,600 worth of services that that provider group practice got paid for the care by the managed care organization. So up here we have our payer, Forest Land Care. They've got this $6,000 for the year for this member. Our provider is New York Medical Group, just a fictional name. They're contracting for an arrangement. This is a single person, not a population, just because it's easier to show as an example. Based on 2014 claims, that member used $2,000 worth of primary care services and had an ER visit for an opioid overdose of $2,600. So their total cost was $4,600. It only cost that provider actually $4,000 to deliver that cost, so they had some savings there based on their own internal efficiencies. The target budget that had been set with the plan was $5,500. So in this model, our target budget is $5,500. We were paid as a provider group $4,600 in claims for that member. This leaves $900 to be shared 50-50 between the provider and the managed care organization. Now we're going to look at the lens here, first of the provider. So again, we submitted as a provider group claims of $4,600 and were paid by the plan. It cost us $4,000. This left us $600 left over because of our internal efficiencies, and then a shared savings, half of this $900, $450, for a total profit of $1,050 for that person. Now we're going to look from the plan side. The plan got $6,000 for the year for this person. They paid out $4,600 to the provider group here. This leaves $1,400. And I've broken it out here, the shared savings portion, the $450 and the $950, because there's not new dollars that the plans are getting. They're not getting extra money from the state to implement VBP. This is going to come out of the shared savings. The shared savings comes out of this metric. So there's that $1,400, $450 comes out for the shared savings that they're now going to split here and send here, so that you got a plus here for the provider group. so that their total profit is $950. Make sense? Okay. So now we're going to do a level 2, a scenario 2, which is still a level 1. This is upside only. We're just going to change the numbers a little bit just to show the example. So again, the managed care organization still gets to $6,000. However, this person had claims for primary care $2,500 and an ER visit now for $3,500, so that the total cost is $6,000. It cost the provider, instead of $4,000 to deliver the care, $6,000. So they still came in under that under the $6,000 in claims. The budget, however, was still $5,500. So in this scenario, the target budget is $5,500. They submitted and were paid by the plan for $6,000 worth of care. Now we're actually in the hole $500. There's no savings to be shared. From the provider lens, again, the claims, $6,000 in claims they had. Their cost was $5,000, so they had a $1,000 profit based on those internal efficiencies, but there were no shared savings, so their total profit is $1,000. From the managed care organization, they got $6,000 from the state. They paid out in claims to the provider because the provider billed them for these $6,000. They paid out in those claims $6,000. They didn't have any profit, they're neutral, and there was a total loss that they're absorbing, so their profit is 0. And so a question, in this scenario, how many dollars are at risk for this VBP contractor or provider? 0, right, thanks, good. So it's level 1, upside only. So now we're going to move to, everyone understand that, makes sense? Okay, because it's no risk to the provider group. So in a level 2 arrangement, same numbers here, $6,000, $2,000, $4,600 in primary care claims. Provider costs $4,600. We're back to the same numbers that we used in the first model. The target budget is $5,500, and here we still have $900 now in shared savings. So it looks a little bit different now for the provider because we were paid $4,600 in claims. It cost us $4,000. We still have that $600 difference, but now instead of getting 50% of these savings, we get 90%. 90% of 900 is $810. So now the provider actually has more dollars, so it's $1,400, $1,410 to share. From the managed care side, $6,000 that they got from the state. They paid out $4,600 in claims. This leaves this $1,400 difference, but now they're paying $810, 90% of that shared savings to the provider group, because in level 2, that is the roadmap guidance that instead of that being a 50-50 split, it's a 90-10 split. If there are losses, then that split of losses is around 50-50. So for the plan, $810 minus that $1,400 leaves the plan with a profit of $590. I always want to emphasize that because often these levels get talked about absent or in a separate conversation than the quality metrics. So if there are 10 quality metrics, at least half of them need to be met in order to say that the provider group met those quality metrics and was eligible for those savings. If in the case of losses, they don't meet them, then the risk level can go up from 50% up to 90%, depending on the percentage of metrics that were met or not met. And there is a slide about that I'll show you. And again, these are all kind of guidance. The whole goal of the state is to give a lot of flexibility to encourage the adoption by both practices, provider groups, and managed care organizations. And these were all informed by a lot of stakeholder input. So now, in this scenario, if the total claims was $6,000, instead of in this situation, the provider had claims of $4,600. If the provider had claims to the managed care organization of $6,000, how many dollars would be at risk for the provider? So it's a level 2, and our target budget was $5,500, and we've now gone over at $6,000. And there is a 50% sharing of losses. $250. Thank you. Yes. So we're $500 over our target budget because we've agreed to take on a level 2 arrangement that has some risk. We're going to share that risk at a 50% level. if we met at least half of our quality metrics. If we only met a third of the quality metrics, then this could be a little bit higher proportion of that $500. So in a level 3 arrangement, so we have, again, the $6,000 that Forest Land Care gets from the state. The costs here are $4,600. The provider cost is still $4,000. The target budget is $5,500. But the scenario is a little bit different. It cost that provider $4,000 to deliver that care. Their target budget was $5,500. So their profit is $1,500 at the provider level. For the managed care organization, they still got $6,000 from the state. They paid out prospectively $5,500 to the IPA for this member, to the provider group, the contractor, leaving $500 left over. So the question here is, if in this scenario the total cost of claims, however, had been $6,000, how many dollars would this provider group be at risk for? Did it? 500, yes, right. So the $6,000 is, was the claims that they were paid by the managed care organization, or that they got. It cost them that. They only got $5,500. That whole $500 gets absorbed by this provider group because they're doing a level 3, kind of an all-in. Okay, are these pretty clear? Okay. So what's the role of quality measurement? So this is this slide. It's not as overwhelming as it seems. There's kind of two 50%, so it gets a little bit confusing. One is the percentage that gets returned to the contractor, and one is the percentage of quality metrics. So this is what's the guidance in the roadmap. And this is not biblical. This does not mean this is the way it has to be done. This is just what is recommended and what experts had recommended to the state. So the important piece is that the efficiency, coming in with the shared savings is the first half of the equation. The second is, did we meet our quality metrics? So the roadmap guidance is that at least 50% of the quality metrics get met. So if there are 10 measures on which you're going to pay, what we call our P for P or pay for performance measures, then 50% of the savings get returned to the VBP contractor. In a level 2, where they're taking on risk, again, it's that 90-10. 90% of the savings would get returned if there were savings. And then it's prorated based on the percentage of targets that get met, unless there was no improvement in quality metrics or quality worsened. If there are losses, then in the example we showed that responsibility for up to 50% of those losses that could go up to as high as 90% in a level 2 arrangement if fewer than 50% of the quality metrics got met. So the suggestion here is that the percentage gets kind of prorated based on that percentage of quality metrics that got met. So if you changed your metrics, and instead of meeting 6 of them, you met 4 of them. They're different metrics, but out of 10, then 40% of those savings could be shared, for example, as opposed to 50%.
I guess the part that's confusing me is the quality worsens at the bottom there. So that,
yeah, I mean, it's if there really aren't quality improvements, and we this probably is could say. This is kind of taken from the roadmap, this table, but yeah, if you didn't meet any quality metrics, right? If it were 0, if we failed all 10 performance metrics, and we didn't meet kind of that performance improvement,
and
then
does the state use the same thresholds as CMS for quality metrics?
Okay, so that's a good question about how do we determine whether a quality metric gets met or not. And this is determined. This is left to be flexible between the contractor and the managed care organization. In DSRIP, as you know, for the pay for performance measures, it's a gap to goal, closing it by 10%. That could be followed. That could be the decision between the contractor and the plan, or they could use a different methodology. So just coming in, different plans have used kind of different strategies over the years for this, and we didn't want to discourage kind of methodologies that were currently being used. It is not a gap to goal. It is between the baseline performance for that kind of contractor group, what is known based on quality metrics for this provider, and that plan at baseline, and then was there improvement? Did they come in and do better than the previous year? So In this world, so you have the contracting process, you select on the measures, and what actually the roadmap says is reporting on the Category 1 measures. So ultimately, we will be asking the plans to report to the state on all the Category 1 measures. But the ones that get paid upon between a contractor and a plan, a managed care organization, are determined between them. And again, it can be a minimum of one. In our pilots that we have total care pilots, we have 1 integrated primary care pilot, and 2 HARP pilots, 2 pilots, for those with serious mental illness and substance use that are currently ongoing. The pilot program was a program to kind of help jumpstart VBP in the state, so they got some incentive dollars, some dollars to support that. We have about 12 pilots that are currently ongoing. One of the things that they had to agree to in the pilot process was to become a level 2 in a risk-sharing entity in the second year. But there is no requirement that in standard VBP land. There is no requirement for level 1 this year that you have to go to level 2 next year. You can stay at level 1 forever. We think there's greater opportunity though, and as practices get more comfortable with it, experience shows that most people want to move to a risk-sharing type of arrangement kind of down the road. And then again, it's these quality metrics that determine the percentage of shared savings or shared losses. So this is kind of just summarized in kind of pictorial form what I've already said. But again, if you're a higher, one of the things that we keep reiterating, if you're a higher performing organization, you're going to have a higher target budget set. You're going to have a higher ceiling within which to come under, because there's a formula for kind of taking that into account, that you've been a high performing organization. Our categorization, we asked the clinical advisory groups that help convene on our quality measures, and we convene groups around each of the measure sets to help inform the quality metrics. Category 1 measures are the ones that you're hearing me talk about. These are ones that are relevant, reliable, valid, and we also had to look at these measures. Was it feasible? Was there information and testing at a provider level, at a provider or contractor level, as opposed to at a statewide plan level or at a state governmental level? And so there were some category measures that got knocked out because there was no experience nationally with that measure at a smaller level on a provider level. Others got knocked out because there was just not enough volume in the state. So an example is in our pediatric measure set, children aren't included in the measures because pediatric HIV, mother-to-child transmission, has virtually been eliminated in New York State. We don't have enough children with HIV to even include them. If we had high-performing measures already and the state performance was above 90%, well, we need to work on something else. We need to work on diabetes improvement or blood pressure or whatever. We don't need to improve on 90%. So those measures were knocked out. Category 2 measures were measures that were considered desirable but yet needed testing, and some of these are getting investigated further in our pilots. And Category 3 were kind of dream measures, or measures where it really wasn't, there wasn't either evidence to support the measure, or they just weren't reliable or feasible in any way. The pay for performance measures, again, I've talked about the pay for reporting measures, the ones that in these contracts the plans still have to report to the state. And in fact, for this first year, for these claims-based measures, what we're going to do is the plans already report these metrics to the state. We're just asking for the attribution file for the given VBP arrangement. So if a plan has, let's say Fidelis has a plan with an IPA here in the Adirondacks, we need to know who those members are, what is that attribution file, and then we will kind of re-aggregate those numbers at that contractor level so that the plan can know what those reports are, what those results are at that contractor level for a given measure. There was quite an extensive stakeholder feedback that's been going on since 2015 that have convened. So this is just our clinical advisory groups. So they meet once or twice a year. They go through this technical review that now that we're caught up, or we're kind of doing in real time. We have a steering VBP work group that then gives the final sign-off and blessing, and then those measures get published. And we this year have published them at the same time as we're reporting our publishing our reporting manual for 2017. which just came out at the beginning of this month, beginning of November. We've also published the 2018 VBP measures. So what you'll find on our website now is those measures that are available for 2018 VBP contracting. And then the data collection and the reporting year starts, and then the year ends, and the cycle continues. Other things that are going on besides our clinical advisory groups and the steering work group is we are working then on kind of this measure feasibility teams. So for each of the arrangements, we have groups working on the measures, and how are we going to report these measures? How are providers going to report them to the plan? How are plans going to report them to the state? And trying to iron all of this out. For the claims-based measures, it's pretty easy. We have a methodology. For those that are medical record review, we don't yet have a full plan. So for like controlling high blood pressure. We were asked the question I often get asked is, why don't we have any surveys? Why aren't CAP scores in here like they are in district? Surveys are expensive. They're labor intensive. The thought to be able to do these, at least early on in VBP, everyone felt overwhelmed. So please, please, please don't include any survey measures in our early years of VBP. So that's why you don't see any CAP scores in our measure sets for VBP compared to DSRIP. So these are the groups, and these slides I know are going to be made available, so they just didn't print them all out for, I think, just to save paper. So that's all that's here. The other thing that's going on is that there's some clinical validation groups that we're working on for behavioral health episodes and HIV that we're working on with Alterum for a couple of the arrangements. So just this summer, what we've done around the engagement process for this 2017-2018 annual cycle, we've convened all the clinical advisory groups twice this summer. We have our task force group, which includes provider groups, provider representation, managed care representation, plan association and provider association groups, and then 12 measures that were newer measures, particularly around behavioral health, went out for public comment, 2 of which are in our primary care measure set around substance use disorder, for a total engagement of over 50 organizations, almost 50 hours of actual kind of physical face-to-face time with over 200 stakeholders engaged in that process. I just included this slide just to kind of familiarize people, if they weren't, with terminology. Another term for claims-based measures are administrative measures. So these are measures that can be entirely derived from claims. This has kind of been validated as an okay process. Hybrid measures are probably better because you're then supplementing them with medical record review. So we just had a conversation with one of the PPSs around a project, and there's some discrepancies between what they get when they add kind of a medical record review to the claims review. Some claims get lost in the grouper process, et cetera, and how can we help to address that? There will always, or commonly, there can be some differences, but in some measures there'll be a lot of agreement with what you get when you do a manual medical record review, comparing it to a claims-based review. Proxy measures are measures that are being considered by our RIOs and qualified entities, where they approximate the measure specifications to kind of have looser guidance to try to be able to capture them from electronic health records or data registries. And then coming down the road are electronic continuous quality measures that are being recommended by CMS. Right now the state is not collecting these, but is piloting their use. But I think that's going to be coming more down the road. These are some examples of claims-based measures that can be totally determined by claims. Adherence to mood stabilizers, breast cancer screening. They have numerator and denominator definitions by the measure steward. These are non-claims-based measures. It's not that you can't get any information about claims. You can get good measure information around cervical cancer screening, but you get better information if you enhance it with supplemental reviews. So working on these additional measures and how to kind of get them reportable in a VBP world. As I said, at the end of end of each year, and this year it was the first week of November, get published not only the measure sets for the following year, for the subsequent year, but also the reporting manual. Like you have the DSRIP manual, measure specification reporting manual, we now have one for VBP for this current measurement year that they'll start reporting on after the year ends. This is an example. The next 4 slides are just the measures. Again, what they're listed in alphabetical order. This lists their measure steward, whether it's CMS, National Committee for Quality Assurance, or whoever it is for the given measure, whether the measure is National Quality Forum endorsed, whether it's an endorsed measure or not. So if it is, it's got a number. When you go to that site, you can just put in that number and it'll roll up what the numerator description is and the denominator description, and then whether the state recommended category is as a pay for performance measure or as a pay for reporting measure. The additional clinical advisory group that we convened this past year was a children's advisory group, because there was a paucity of measures that were relevant to pediatrics, and kids would be in a total care arrangement. So there was an addition of 6, I think, or 6 or 8 additional measures that were already fairly standard HEDIS measures. They were already in QARR that got added around adolescent well care visits and some other well care visits and things relevant to children. So this is just kind of them in their entirety. Some of the pay for reporting measures, P for R measures, again, ultimately the goal is to have all of them be reportable. Again, in 2017, it'll just be those that the state has defined as reportable. But a contractor could decide that they want to make a P for R measure a P for P measure. They could decide that they want to pay on a given measure, even though the recommended guidance is a pay for reporting measure. So there's no requirement here around these. These are just suggested classifications. A lot of measures around diabetes, controlling high blood pressures here. Again, these frequency of well child visits for the various age ranges, and then some preventive care screening measures. These are measures that still need some work, even though they're pay for reporting measures, about how we'll capture that information. And then statin therapy for those with diabetes or heart disease, and again, measures that you're probably fairly familiar with. So just to kind of wrap up, each VBP arrangement does have its associated measure set. These kind of were informed by our clinical experts that the state convened. These include these Category 1 measures, pay for reporting and pay for performance. Contractors would be tailoring the arrangement based on the type of service that they provide, remembering that the total care arrangement is a total population type of arrangement. So these are population health-based arrangements versus these kind of total cost of clinical events, which would be the maternity episode or integrated primary care, would be examples of episode types of arrangements. These quality outcomes are measured on the members to whom are attributed to a given provider group. So care coordination becomes important even for those that we haven't seen come through our doors yet. Quality is important, and the savings don't get earned without meeting these minimum quality thresholds. Most of these quality 1 measures, again, were already reported by providers and plans. So most of them that are in the arrangements are ones that providers and plans are already familiar with. We're trying to reduce that additional burden here. And out of the entirety of this 2017 measure set, there were only 5 Category 1 P for P measures that weren't currently in QARR. Again, we're not asking them to be reported on anyway if they aren't claims-based measures. This is the piece about that the quality performance impacts that target budget, and that quality performance is a factor in determining the percentages of shared savings or losses, and that the IPA or the ACO, whoever is negotiating for the providers, should make sure that the network practices also kind of know what these measures are, know what they can be working on, and so can focus on them. And a common thing that we hear is there's too many measures, and I certainly agree with that. In our HIV world, one year I had to report out, I was asked to report to our patient council steering committee for the hospital on quality, and between the plans, the federal government and the state and all the measures, some of the measures were the same measure, but they wanted it reported different way with a different numerator or denominator definition. It was over 100 measures. It was ridiculous. So we get that, and we are trying very hard to kind of streamline and have measurement serve multiple purposes to avoid that duplication. And again, out of all those measures that you saw, there's no requirement in terms of pay for performance except one. And the requirement is that in contracts that you use at least one of those measures to pay on, that at least one of these 30-some measures get used for payment purposes. And the contractors had no troubles with that. Most of them are using 5 to 10 of them. And then lastly, I thought I would close with a little jingle, if you'll indulge me. V for value in VBP. V is based on quality. P is payment for great primary care. L in levels 1, 2, 3. A, arrangements of all sorts. N, new measures and reports. D, diffusion through cohorts. And that will bring us back to value-based payments levels arrangements, new diffusion VBP.